techniques, etc. اوكي هلا this time رح نحكي عن الكلاسيفيكيشن and genetics. عم بجرب شيلها هيدي كيف بدي شيل الاسود. ما رح بقدر شيل. راحت. عظيم. اوكي okay. Today we're going to talk about various sarcomas and techniques of how we can diagnose them. Not radiologically mainly by investigations such as genes, such as immunohistochemistry. Now, let's start with the following. Heterogeneous tumors of mesenchymal origin are known as sarcomas. There are two main classes, bone sarcomas and soft tissue sarcomas. More than 100 different histopathologic subtypes are defined. في 100 genus, and you have to realize how much difficulty the histopathologist has in arriving at the diagnosis. About 50% of cases are associated with characteristic somatic molecular abnormalities and often gene fusions. Many are associated with germline predisposition syndromes. Let's speak about bone sarcomas. It's less than 0.2% of human cancers, so it's rare. We see in the United States 3,000 cases per year, and you have so many centers. You can see that the experience on the field is very little because there are only a few centers that really have a certain number of cases and they can develop the experience. Of these 3,000 cases, 1,500 deaths occur a year. And these occur most often in children, adolescents, and young adults. Yani these tumors, sarcomas, are more common in the young. The most common subtypes, as we know, are osteosarcoma, 35%, chondrosarcoma, 30%, and Ewing sarcoma, 16%. Ewing sarcoma associated with FLI1 gene fusions, yani extraskeletal Ewing sarcoma, is rare, but it does occur in children. What about the soft tissue sarcoma? Soft tissue sarcomas are less than 1% of human cancers, and approximately 12,000 cases a year. 4,500 deaths occur per year. Min 12,000, 4,500 die. 45% of over 100 subtypes are associated with recurrent molecular or cytogenetic abnormality. Different types can occur in different age groups. Some subtypes. يا جماعة رح بدكم إياها هيدول هل lecture. I know it's boring, but we often put questions on these because we think it's important for a candidate who's training to know about them. You have to take this lecture from Dr. Khalid and memorize it to be able to answer multiple choice questions. Some subtypes with associated abnormalities include desmoplastic small round cell tumors. And you have to remember that what are the fusions with it? They do these studies, and it's in EWSR1WT1. Myxoid liposarcoma, gene fusions are DDIT3. Believe me, I personally don't know them, but I have to memorize them when I'm a candidate for an examination such as the board. Infantile fibrosarcoma, gene fusions involving NTRK. Alveolar rhabdomyosarcoma, gene fusions involving PAX or FOXO. Clear cell sarcoma. This is the way they can identify these tumors. They are all spindle cells. Some have round cells. They are very difficult to differentiate. It's only by these gene studies that we're able to distinguish clear cell sarcoma from epithelioid sarcoma, from alveolar rhabdomyosarcoma. This is done by a histopathologist, and this requires a good knowledge about these genes. Ewing sarcoma. Ewing sarcoma demonstrates a monotonous population of small blue round cells in soft tissue tumor. But look at this. This can have, any other tumor can have it. Rhabdomyosarcoma can have it. Mesenchymal chondrosarcoma can present as such. Lymphoid tumors can present, but with larger cells, which are round. You have to think of these tumors that you need special studies to differentiate it. For instance, we know CD99 is common with Ewing sarcoma. Look at liposarcoma. You see that the image demonstrates well-differentiated liposarcoma with variable size adipocytes with nuclear atypia. So liposarcomas, you can have a variety of presentations, and you have to be able to tell what's a myxoid liposarcoma, what's a round cell liposarcoma, etc. Okay? This is an osteosarcoma. You see atypical spindle cells laying down malignant osteoid. And you have an undifferentiated pleomorphic sarcoma, what we used to call malignant fibrous histiocytoma. And this demonstrates the atypical fascicular proliferation of spindle cells with increased mitotic index. Let me tell you, at the Fellowship for the Royal College of Surgeons of Canada, we have to know the pathologies of these. We have to know which are the spindle cells and which are not. So for this reason, it's very important that you know these slides, that you memorize this lecture. There are three classes of sarcoma genomes. Simple karyotype with a defining translocation gene fusion, simple or complex karyotype with a specific mutation. And you have complex karyotypes with multiple chromosome rearrangements, duplications, and deletions. So this is something really you have to know. These are gene fusions and how they occur. I think you should read about them, and you have to see further about these gene fusions, the FISH study. So I'm going to go to another lecture related to this, because I think I have the wrong lecture in place. كنت تحملوني يا جماعة.
دكتور جون. ساركوما سهلة اليوم. صحيح صلاح بالجدول. دكتور جون.
خالد.
دكتور جون.
عم تسمعوني؟ لان ما عاد
ايوه
تقدر
ايوه
توصل. ما
لا خلاص عم نسمعك خلاص.
طيب great.
Yeah. كم مصادات كمان؟
هلا مش الحال. Good great.
لا
لأن يا أخي كتاباتي from a wrong series. I tried to change it بس I couldn't. هلا راح برجع سوري يعني على هيدي. The clinical utility. عم تسمعوني خالد؟ يا خالد.
دكتور جون عم نسمعك.
Okay. The clinical utility of molecular testing for sarcomas. Arriving at diagnosis for cases.
دكتور جون العفو، السكرين مش واضح.
مش واضح.
لا
هاي المشكلة. ما بعرف شو قصته اليوم عند الكل.
لا كان عم يمشي كويس.
هلا ماشي.
لا هلا
رح برجع بفوت لأن
أيوة
عم بتعذب تصلي علي من وقت ما هيدا.
اوكي. صراحة
بين يا شباب.
مبين يا دكتور جون واضح.
واخيرا نشكر الله. يلا. اوكي بس بدنا نشيل هيدا الاسود من هون. ما عم بقدر اشيله. يلا ماشي الحال. اوكي. Arriving at the diagnosis for cases with ambiguous histology, these studies and investigations are done. An example would be the diagnosis of small round cell tumors, as I mentioned before, and في كتير tumors بيعطوكم بالhistology small round cells. And you have a refining molecular subtype of rhabdomyosarcoma, which is associated with PAX-FOXO fusions. طيب. عندك البيديجرا مشان gastrointestinal tumors. عندك various types which respond to imatinib. They help us in the treatment. For instance, confirmation of a synovial sarcoma in a 76-year-old individual. And we know this is quite rare at this age, aiding in the diagnosis for cases with dedifferentiated histology. يعني أوقات بيجينا cases ما بنعرف شو هن. So we have to use immunohistopathology for the diagnosis. We have to use genes at times. We have to use all kinds of studies to help us differentiate from one synovial sarcoma to another. For this reason, nowadays we call them all undifferentiated sarcoma because it's quite difficult to differentiate at times between one and the other. Let's come to the round cell small tumors, the small round cell tumors. You have a homogeneous, light microscopic appearance of small round cell neoplasms. فرجيتكم إياها. But what produces this? طلعوا Ewing sarcoma, rhabdomyosarcoma, mesenchymal chondrosarcoma, desmoplastic small round cell tumors, round cell liposarcoma, and poorly differentiated synovial cell sarcoma. And we know that neuroblastoma also can give us this picture. Identification of a characteristic gene fusion can help make the diagnosis, especially in neuroectodermal Ewing sarcoma, ectodermal sarcoma, meaning that these are Ewings which occur in the soft tissue. So we have to have these. Now, cancer predisposition, we have multiple conditions that really let us be predisposed to cancer. One of them is the Leaf-Romani syndrome. Other germline heterozygous inactivating mutations in TP53. You have childhood onset of sarcomas in these patients who have a Leaf-Romani syndrome. You have retinoblastoma syndrome in osteosarcoma. You have a germline heterozygous inactivating mutation of retinoblastoma 1. These occur in osteosarcomas. They predispose patients to this. On the other hand, you have familial adenomatous polyposis, germline heterozygous inactivating mutations in APC. Most APC mutations cause a condition called familial adenomatous polyposis. All these have predisposing conditions. And for this, we have to know how and what studies to ask for to differentiate between them. هلا that lecture becomes easier. هلا بقدر اخذ نفس. And these are difficult points to remember and to discuss. If you look on the left-hand side of this table, you have a syndrome. And then in the middle, you have the gene. And then on the right-hand side, you have this type of sarcoma. A Rothmund-Thompson syndrome is associated with osteosarcoma, and it has a RECQLA gene. Neurofibromatosis type 1, the gene is neurofibromatous 1, and it gives us a malignant peripheral nerve sheath tumor. Costello, the harass, is for rhabdomyosarcoma. Beckwith, Weidemann, and this whole list in the middle, again, is a predisposition for a child to have rhabdomyosarcoma. So, the take-home message that what I'm trying to give you is that sarcomatous lesions are a heterogeneous group of diseases with over 100 subtypes defined by histopathology. Genetic testing can help with the diagnosis. Molecular subtyping and treatment selection. A significant fraction of sarcomas are associated with either a germline cancer predisposition syndrome or a genetic syndrome with other phenotypic features. Soft tissue sarcomas are uncommon. They are an aggressive group of tumors with an incidence of 5 cases per 100,000 people per year. 1% of adult solid neoplasms and 7% of pediatric solid neoplasms. So this is quite rare. There are more than 50 histological subtypes of soft tissue sarcomas. Rhabdomyosarcoma, we all know, is the most common soft tissue sarcoma in children, whereas undifferentiated pleomorphic sarcoma is the most common in adults. When we say undifferentiated pleomorphic sarcoma, is the name that was given for malignant fibrous histiocytoma. So you have to keep this in mind, that the name has changed. Soft tissue sarcomas are predominantly located on the extremities and trunk, and some are found in the retroperitoneal area. I recall when I was operating on a liposarcoma. I was operating, it was localized to the medial aspect of the proximal thigh. The lesion measured around 15 kilograms in size. I reached the inguinal area and I found that there was an extension. I had to open the abdomen and I found that the tumor was massively present in the retroperitoneal area. So always think that when you have a soft tissue tumor, like a leiomyosarcoma, like a liposarcoma, investigate the retroperitoneal area. Do a CT, do an MRI, make sure that there is no lesion in that region. Patients with soft tissue sarcomas are significant risks of local recurrence and lung metastasis. The treatment of a soft tissue sarcoma should be centralized in tertiary centers. What I mean by tertiary centers, we don't advise people who don't have any experience in the treatment to take care of these. First, in the way they take the biopsy. Second of all, the way they manage the treatment. It should be a multidisciplinary approach. There should be teams comprising oncologists, orthopedic surgeons, radiologists, pathologists, and patients should be referred prior to any biopsy or excision. It's preferable that the center that is going to do the definitive surgery do the biopsy or do the excision. Keep this in mind. Dr. Khalid, you can prepare this. You can do a multidisciplinary approach, get the people together, and you can prepare a tumor center. Tumor centers can be easily prepared, but with devotion and understanding of the group, of the multidisciplinary group. This is easy to do. The cornerstone, يا جماعة هيدا مغطيت لي كل شيء. The cornerstone of treatment of non-metastatic disease is complete resection of the tumor. We always like to resect the tumor with some margin. In the past, we used to say we needed the margin of, let's say, 3 centimeters or 2 centimeters. Nowadays, as long as there's a margin of normal tissue, that would be sufficient. And we have methods to analyze and describe this. Amputation was common in the past, whereas current clinical practice entails limb-sparing resections in the majority of patients without compromising survival. Adjuvant radiotherapy and chemotherapy for metastatic disease may also have a role in the treatment of selected patients. The history of the patient is important. It gives us clues. For example, tumors that do not change for years are more likely to be benign, especially the soft tissue tumors. And there are malignant tumors which are quiescent for years, like synovial cell sarcoma. However, pay attention. A mass larger than 5 centimeters with rapid growth, swelling, or causing neurological symptoms suggests a malignant tumor, and further investigation is needed. You can have a superficial lesion to the fascia, which is larger than 5 centimeters. Beware. It doesn't mean that being that it's superficial, it's benign. You have to investigate to make sure that it's not malignant. Pain is present in a few soft tissue sarcomas. Pain does not. I have had the synovial cell sarcoma in an 11-year-old boy. He never complained of pain, but he began to see that he had a mass in the inguinal region. So you have to be careful. مش يعني انه موجوع، لا ماني موجوع، روح ما هي شيء، لا. Soft tissue tumors, by definition, most are painless. Okay? There is a poor discrimination between malignant and benign tumors, although it can start after trauma. About 80% of soft tissue sarcomas are deep-seated. When I mean deep-seated, deep to the deep fascia that surrounds the muscle. But even a superficial tumor with troubling characteristics deserves further examination. ما تتركوا ولا tumor. When you see a mass, the first question I ask, is this enlarging in size? Second question, does he have pain? Where is it localized? Superficial. If it's superficial, how large it is. This is important. So all these are important in the clinical evaluation. Imaging. Plain radiographs may reveal a mass in the soft tissue. Just today, I had a huge lipoma in the deltoid muscle. And the patient came to me. She said, Doc, is this a malignant lesion? I told her, I cannot tell. We have to see the images. We have to take proper history. Where is the lesion localized? It's deep. How big is the lesion? All these are important. Ultrasound can identify a tumor and may show if it is superficial or deep. And Doppler can evaluate the tumor vascularization, but otherwise it has very limited use in the diagnosis. So you have to add information, put them together, and then arrive at a diagnosis. And don't be ashamed. You should discuss it with others in the multidisciplinary group. New MRI sequences. Attention. New MRI sequences, such as diffusion-weighted images, can help to assess adjacent tissue infiltration. Yoon et al. Reported an improved confidence level to predict facial involvement with the sequence. And Hong et al. reported better specificity in assessing the tumor margin infiltration. Thus, diffusion-weighted imaging may help determine the extent of the resection, but additional data are needed. Furthermore, MRI findings may help define the histological grade, which is the strongest prognostic factor in soft tissue sarcomas. So, we have studies we can use that will help us, but make use of them. Many do MRIs. Look, it looks malignant, and that's it. You should investigate where is the location of the tumor. How far is it from the neurovascular supply or neurovascular passage, nerves and vessels? You have to investigate it. You should look at the boundaries of the tumor. Where are you going to do a resection? Are you going to do a radical resection or a compartment resection? What should you do? These help you. Crombie et al. Found that peritumoral enhancement, necrosis, or intratumoral heterogeneity at T2-weighted imaging were associated with the tumor grade patient survival. This is very important. Many times they get me an MRI. Sir, does this look benign or malignant? I tell them, look at the heterogeneity. See how much it's heterogeneous on T2. And this will put it forward as a malignant lesion. MRI-based radiomics seems to differentiate between low and high-grade soft tissue sarcomas more accurate. MRI-based radiomics features in soft tissue sarcomas may correlate with histological findings and patient prognosis. So please, again, I tell you, get this lecture and memorize it. What about the biopsy and molecular diagnosis? Patients should be promptly referred to specialized centers where diagnosis is undertaken by multidisciplinary teams. Are we clear about this? Well-defined guidelines should be adopted, minimizing time to surgery, wrong biopsy, and inadequate initial excision. The goal is awareness to increase awareness among general practitioners in recognizing the disease, to establish easy contact with sarcoma centers, and to minimize erroneous surgery. Whoops, excision. And whoops, I went through the tumor by mistake. Well, you need master-minded, master technicians to deal with these tumors. Biopsy should preferably be performed by the surgeon who will also remove the tumor, minimizing contamination of the surrounding structures. You have to be very careful when you're taking the biopsy. The incision should be made longitudinally. It should be made in line with the planned future surgery. The biopsy incision should be longitudinal and short, should not be long. You should go directly to the tumor. Don't separate between different muscles to reach the tumor. Then when you separate between the two muscles, you're spreading the tumor. You should prevent any hematoma formation. If you're going to use a drain, it should be extruded directly near the end of the incision. So this is what I'm telling you. Prevent hematoma. I once received a patient who had a biopsy in the leg. The patient had a huge hematoma collection, and it extended to the thigh. So we had to do an above knee amputation. We could not save that extremity. So be careful. A closed biopsy, fine needle aspiration, or true cut is usually sufficient, with an open biopsy required in some cases. Why? A true cut or Jamshidi needle biopsy, you have to take it through one entry, but redirect the needle when you're within the tumor. Don't take the biopsy from the center of the lesion. Take it at the periphery of the lesion. Why? Because tumors grow outward. They don't grow inward. And if you recall in a previous lecture, when I was speaking about heterotopic ossification, it's the exact vice versa. The growth is towards the center and not extracellular. The use of ultrasound guided biopsy should be encouraged in cases where the tumor is heterogeneous or difficult to locate during physical examination. In deep tumors or those with complicated localization, a computed tomography guided biopsy can be performed. I'll tell you, one of the difficulties in the pelvis is that if we want to take a biopsy, it's so deeply located that we cannot really localize it exactly. And the biopsy, if we're doing a core needle biopsy or a true cut or Jamshidi, we have to go with CT guidance to reach it, or do an open. In the last decade, the use of liquid biopsy, this is new, liquid biopsy, has been studied as a new method for the diagnosis and staging of soft tissue sarcomas. It is based on the identification of circulating genetic material from fluids, including blood, urine, feces, saliva, or cerebrospinal fluid. You can identify the cells in these areas. A study detected circulating cell-free DNA and calculating tumor-derived DNA in 4 of 11 metastatic soft tissue tumors patients in 36%. Review of 4 blood-based biosources, namely circulating tumor cells, cell-free DNA, exosomes, and metabolites, supported the view that they can improve our understanding of how soft tissue sarcomas metastasize, how tumor components reach the endovascular space, and in the future also detect tumor evolution, reveal drug resistance mechanisms, and develop new strategies to prevent dissemination. Next generation sequencing. Remember, it's called the NGS, next generation sequencing, has improved soft tissue sarcoma diagnosis, genomic discovery, and understanding of the underlying molecular mechanisms through detection of gene deletions, insertions, copy number of variants, and structural alterations in multiple soft tissue sarcoma genes, complementing traditional pathological diagnosis. NGS can sequence with minimal DNA multiple genetic loci simultaneously, faster than traditional mutation detection systems, and distinguishing morphological similar soft tissue sarcomas. Furthermore, it provides data that can be useful in the context of personalized medicine, assessing mutations with therapeutic response or resistance. Patients with musculoskeletal tumors can present as an incidental, asymptomatic finding to severely painful lesions with deformity and/or fractures. It is not infrequent for more aggressive tumors to present with significant pain and for more indolent tumors to be asymptomatic. Yeah, you can have something which apparently is very malignant, but they don't have pain. So you have to pay attention to this. Although these are the general rules, many patients will fall outside of this norm. It is therefore imperative that the clinician assessing the patient incorporate all the data available to determine a diagnosis. The presentation will vary depending on the bone versus soft tissue origin, and often depending on the age of the patient, as many very young children will not verbally express pain or discomfort. So you have to be careful. You have to observe. If a child comes in, he's limping, but he's running around as if there's nothing. Even though, why is he limping? You should investigate. The vast majority of soft tissue tumors will present without pain. Pain is not the determinant of malignant versus benign process. In fact, more frequently, benign soft tissue masses will present with pain. Examples are schwannomas and neurofibromas. These can present with an electric shock of pain. They are sharp and shooting. Patients with nerve tumors will frequently have a sign on examination, which will manifest electric shooting pain. But these are the far majority are benign, but these are associated with pain. The site of the tumor should be tapped, but don't apply too much pressure. And when you're operating, if you're applying a tourniquet, it should not be applied on the tumor, because you will promote, if it's malignant, promote spread of the tumor. Vascular malformations and angiolipomas are also tumors that frequently present with pain. Patients will have pain directly over the mass, so you have to be careful. It is hypothesized that the vessels within these tumors have nerve endings within them, that they can be triggered from trauma or thrombosis of the vessels within the tumor. Most malignant soft tissue tumors will not cause pain unless they are directly invading a nerve, bone, or large vessels. Most soft tissue tumors will present as growing mass. Rapid growth is often an ominous sign, a very bad sign. We don't like a mass in the thigh that is growing from 1 month to the other. Then we're alert and we have to manage it. There are some sarcomas that will present with slower than expected growth. For instance, as I mentioned to you about my patient of synovial sarcoma, 11 years he had mass. And then it began to grow, and I took a biopsy, and it turned out to be synovial sarcoma. Most benign soft tissue tumors will often be slow growing or stable in growth. Some lipomas and fibromatosis can grow more rapid and still be benign. Vascular malformations may exhibit a waxing and waning pattern of growth, with patients reporting rapid enlargement followed by fairly rapid decrease in size. The lesion will rarely go away completely, however. What about bone tumors? Both benign and malignant bone tumors can present with pain. Unfortunately, the skeleton is a structure with a plethora of nerve endings throughout its components. Pain is a frequent finding in many active tumors, particularly when the risk of fracture is present. When bone pain is present, patients often report pain at the site of the lesion and may describe this pain as an aching and throbbing in nature. مثل السن اللي عم بيوجعك, throbbing in nature. The patient may report feeling that the pain is deep-seated. It is common for patients with bone pain to report night pain. It wakes them up at night. In situations where risk of fracture is imminent, patients will often report functional pain, such as pain with taking a step or getting up from a chair. Although many benign malignant bone tumors will have pain associated with them, it is not uncommon for patients with inactive benign tumors to present with an incidental finding on imaging that was obtained for another reason, such as in acute transient injury or workup for some other process, such as arthritis or rotator cuff pathology. In other words, they are taking an X-ray for pain in the shoulder and rotator cuff, and they find that there's a lesion in the proximal humerus when the patient didn't even complain of pain. So you should expect these to occur. Young children can be a challenge for assessing the presence of bone pain. Most young children will not report pain, but parents and caregivers may notice a limp or a sudden lack of use of a limb. In any child that presents in such a manner, a full workup, including thorough physical examination and imaging of any areas of concern is warranted. In one analysis of children diagnosed with malignancy, the number one presenting symptom was pain. This points to the importance of care in assessing what pain is in the young child. Occasionally, in the instance of bone tumors, the first presenting sign may be deformity of the limb involved. إذا بتطلع بالosteofibrous dysplasia, it's a good example of such a presentation, in which case the parents may notice anterior bowing deformity of the chin, and the anterior aspect of the tibia is bowed. And this is an example. This is in osteofibrous dysplasia of a 2-year-old child. And you see that there is mild anterior bowing, which will likely get slightly worse with growth. This is the counterpart of adamantinoma, which occurs in adults, but this is benign. Adamantinoma is more or less malignant. Other conditions, such as isolated large osteochondromas or multiple hereditary exostosis, will also often present with what is perceived as painless lumps or limb deformity. Imaging of the musculoskeletal lesions. In the previous lecture, we spoke about imaging of the musculoskeletal system. Now we're speaking about tumors. Radiographic features often play a key role in helping to diagnose many bone and soft tissue tumors. Many tumors will have distinct radiographic features that are characteristic of a specific tumor. I'll tell you, a plain radiograph helps me a lot in making the type of tumor, making the diagnosis in at least 75% of my cases. I know what the tumor is before I ask for other studies from a simple plain X-ray when the lesion is in bone, not in the soft tissues. Such findings can often allow the clinician to limit further invasive and non-invasive testing. Plain radiographs are often the starting and ending point for many bone tumors. When imaging bone tumors, the plain orthogonal radiograph should always include the whole bone in question. Full-length radiographs should be taken, as this may identify an isolated condition versus a multifocal process. You know, in osteosarcoma, we know that there are skip lesions, lesions localized, more proximal, and between this lesion and the primary tumor, the bone is normal. This is a skip lesion. That's why we like to take long X-rays. The radiographic presentation is frequently all that is needed for a diagnosis in many specific bone lesions. In a recent Dutch study looking at a universal country-wide registry, delays in diagnosis were often found to occur at the primary care or generalist level. The authors of the study point to the need to educate the generalists on the importance of early plain radiographs in the management of patients with musculoskeletal pain. Let me tell you something. Nowadays, the tendency is to ask for a CT scan and MRI. Many people come to me saying, this patient has pain. We ask for an MRI, it doesn't show much. We ask for a CT scan, it doesn't show much. Did you take a plain X-ray? A plain X-ray gives you a significant ability to diagnose the lesion. Okay, so really, once you have a plain X-ray, you make diagnosis of the lesion. You don't need much anymore studies unless really indicated. So you have to pay attention. The first question one should ask when assessing a plain radiographic lesion is whether the tumor has a matrix or not. From the matrix meaning that the fill-up of the tumor, the composition of the tumor within its boundaries, within the cortex, within the lesion's wall. from this matrix, we can be able to tell a diagnosis. This is often clearly seen on the plain radiographs. The two matrices one would see will be cartilage or bone. If you look over here, you see that the calcification is more dense than the regular bone. You see that there is a popcorn appearance of the lesion. You see that it's well localized. You don't see much erosion around the lesion. In this lesion, I would say this is an enchondroma. Many tell me, what should we do if these enchondromas have pain? I always tell them you should look at the cortex. See, is there any erosion telling you that there is a change to a malignant lesion? In addition, you can do a technetium scan and you see if there's an increased uptake. This will put it more in the malignant lesion. So these soft tissue tumors, which are cartilaginous, they can cause scalloping or erosion of the cortex. And this can give pain, and it tells us it's more or less towards the malignant side. So the cartilage appears in rings and stippled appearance. On the other hand, osteosarcoma, the bone is dense, and you see that there's extra osseous extension. And this is characteristic of an osteosarcoma. There can also be a fibrous tissue matrix, but this can be harder to discern from other lytic processes on plain radiography. The matrix can then either be defined as aggressive appearing, as in the case of chondrosarcoma, or non-aggressive, such as enchondroma. If no matrix is present, then the lesion is described as a radiolucent lytic lesion. It is important to keep in mind that in the case of lytic lesions, greater than 30% of the calcium matrix needs to be lost. Yani you have to erode or destroy or eat up 30% of the bone before it becomes apparent by a typical plain radiograph. The Enneking's classification system for benign tumors is often a good starting point for classifying bone tumors. Enneking described 3 types of bone lesions, which he defined as latent, active, and aggressive on plain radiographic features. The latent tumors have clear and distinct borders, often with sclerotic rim around the lesion. An example of a latent tumor is non-ossifying fibroma, picked up as an incidental finding. This is the Enneking staging of benign bone tumors. Latent is clear and it's distinct in its boundaries. It has no erosions. Active is indistinct border, but you can still have the lesion well contained, and aggressive is indistinct border. There is no longer contained within the confines of the bony cortex, and it can erode the cortex. It can grow out of the cortex. So don't forget, benign lesions are classified into latent, active, and aggressive. So don't forget this. These are examples of the 3. In the lesion in A, you see that you have an inactive lesion and it is surrounded by sclerosis, and this tells you it is an inactive lesion. In B, you see that the lesion is expanding bone, you have lysis of bone, you have erosion of bone, but it has not passed through the cortex. And in C, if you look at the distal femur, you see that it has penetrated the cortex and it lies in the soft tissue. Active lesions do not have a distinct border and will not have a sclerotic rim. They indicate a tumor that is growing, but not aggressively, such as unicameral bone cyst. Aggressive tumors will show expansion of the bone, destruction of one or more cortices, and indistinct borders. And an example of this will be a giant cell tumor. Examples of aggressive tumors are frequently giant cell tumor of bone and in other aneurysmal bone cysts. Both active and aggressive imaging features can also be present in malignant bone tumors that are lytic, such as telangiectatic osteosarcoma. Okay, you should not confuse the picture, but you should know about the differential diagnosis. At times, a giant cell tumor will be so aggressive that it's quite difficult radiologically to distinguish from a telangiectatic osteosarcoma. Computer tomography. Computer tomography utilizes multiple plane radiographs taken in different planes to generate a three-dimensional image of a particular body part being assessed. The benefits are not that one can see the three-dimensional nature of the bone and in that assess the true relationship of the tumor to other surrounding bone and soft tissue. CT scans can allow for assessment of the structure, integrity of the bone and the matrix of the tumor. CT scans are also less expensive than MRI and therefore may be favored in circumstances where cost containment is important. It does not provide the soft tissue detail that can be assessed by MRI, however. The other downside to CT scan is that because one is effectively using numerous X-rays to generate an image, the radiation exposure is significantly higher than the typical 2 to 4 views one may obtain for a typical long bone. CT scans can carry up to 200 times more radiation exposure than a single plane radiograph. For this reason, it is important to use CT scan with some prudence, particularly in young children, where the exposure to multiple CT scans has been shown to have a theoretical risk of future cancer development. CT scans can be useful for certain tumors, particularly in situations where the three-dimensional nature of the cortical bone may need to be assessed. Osteoid ostiomas, which are cortically based tumors that frequently show a clear nidus on CT scan, are an example of a tumor for which CT scan can be extremely useful as a diagnostic tool. In other regions of the body where the complex nature of bone is not well seen on plain radiographs, such as the sacrum and pelvis, as I mentioned before, a CT scan can be very helpful. Magnetic resonance imaging can be useful as a modality beyond plain radiographs if plain radiographs do not definitely allow for determination of the lesion in question or if further information regarding soft tissue involvement or marrow edema is warranted. It is often less informative about the structural integrity of bone. So you want to look at bone, you want to identify the structure of bone, CT scan, but you're giving the patient a huge amount of radiation. It's less costly than an MRI. An MRI will tell you about the matrix, tell you about the content of the tumor. In addition, it will tell you about skip lesions. In addition, it will tell you about soft tissue extension. So you have to keep this. And when you inject with MRI intravenously, gadolinium, providing the patient accepts or his general or kidney function is good, you can tell a lot about the soft tissue extension of the lesion and its relationship with the neurovascular structures around it. MRIs allow for detailed assessment of tumor-associated edema, which can be useful in distinguishing subtle pathologic fractures as well as tumors showing aggressive behavior. There is no better study than MRI when one is concerned about the soft tissue extension of a tumor, and therefore should be considered when clear cortical disruption is seen on a plain radiograph. يعني إذا تعملوا صورة عادية على a tumor and you see that the cortex is destroyed, you want to know more about the soft tissue extension, you should ask for an MRI. And this can be associated with gadolinium. So be very careful about this. It allows one to see more clearly the borders of the tumor and also allows for the distinction of a cystic versus a solid lesion. Gadolinium goes to sites of high vascularity and will also allow for determining the vascular nature of the tumor in question in some cases. This can be particularly important in the assessment of malignant tumors. In MRI of the whole bone in question is absolutely necessary for any malignant primary bone tumor. This is done to rule out metastasis. MRI is unnecessary in the clinical workup of an adult patient with presumed metastatic disease. Plain radiographs are usually adequate for assessing risk of fracture, and since wide resection is rarely performed for metastatic disease, knowing the exact margins of tumor is unnecessary. Bone scans and other nuclear imaging. Nuclear imaging is a modality that we spoke about last time. It can be helpful in the assessment of bone tumors, but are often more expensive tests and expose the patient to higher levels of radiation, so should be reserved for when a true need for further diagnostic assessment is determined. There are several different forms of nuclear imaging, which we discussed the last time. We spoke about indium, we spoke about technetium, we spoke about gallium. So there's no sense of going on these. Now we come to PET scans in tumors, which is quite helpful in our study. Now, we spoke about the three-phase scintigrams and what each one is significant. So you have to keep this in mind. Now, we tend to tag white blood cells, and this is a white blood cell scan. We tag it and then we re-inject it. This is in indium and gallium, and this is present around infected bone, which is not our discussion today. Now, in other nuclear tests, this is, we discussed last time, and I'm repeating it. Why? Because it's used in soft tissue tumors. In other nuclear tests that we frequently see ordered by our medical oncology colleagues is positron emission tomography, PET scans, which is a nuclear test that utilizes radiotracer labeled glucose, 18-fluorine deoxyglucose, FDG, to identify metabolic active areas of the entire body. This test is not just limited to the skeleton, but can detect high metabolic activity anywhere in the body, tumors as well as healing injuries, infections, which show an increased FDG uptake. So this test can be very non-specific and is usually reserved for patients with a known diagnosis of malignancy when one is in search of metastatic disease. Recent cost analysis comparing PET scans to other modalities such as chest radiography or chest CT scan to survey for recurrent or metastatic disease in primary bone sarcomas found that PET scans was never found to be cost effective. Therefore, ordering of a PET scan should be coordinated with the medical or pediatric oncology teams and not as a first-line test for assessing for bone or soft tissue malignancy. Now, what is the influence of plain radiographs on soft tissue tumors? They are often less helpful for the diagnostic purposes of a soft tissue mass. There are a few instances where plain radiographs can be diagnostic or at least narrow the diagnostic possibilities. Lipomas, particularly large ones, are examples of tumors that are often seen on plain radiograph. This shows you a plain radiograph of an intramuscular lipoma, while the arrow points to an area of decreased density. You see the radiolucency, and this is very important. That lets us say, oh, this probably looks like a lipoma. This is because fat has a lower density than muscle. On plain radiographs, one can see the contrast of the lower density fat adjacent to or within the higher density muscle and skin. Let's go back. You see, this is within muscle, and this is less dense than the surrounding muscle. So keep this in mind. Soft tissue calcifications on plain radiographs can also be helpful in narrowing the diagnosis. Certain benign conditions, such as synovial chondromatosis, heterotopic bone, and phlebolith, vascular calcifications within the vascular malformations, will all exhibit soft tissue calcification. Yani if you see vascular malformation, you can see phlebolith throughout the extremity. This is local form calcification. Several malignant conditions will also show calcification within the soft tissue, such as synovial sarcoma and extraskeletal osteosarcoma. I've had a few cases of synovial sarcoma around the knee on the posterior aspect of the popliteal region. This mass was solid, and that's the way we distinguished it from a Baker cyst and the localization. And on plain X-ray, there was calcification. In extraskeletal osteosarcoma, we have calcification. So if you're giving a case, the differential diagnosis, you should put synovial cell sarcoma, skeletal osteosarcoma, these also all produce calcification, heterotopic ossification, also liposarcomas on rare incidences produces calcification, leiomyosarcomas likewise. Both of these latter conditions will often have other concerning features on MRI or CT. CT scans for soft tissue masses can be used to delineate a calcified body, such as the case of a heterotopic bone. In the case of heterotopic ossification, the calcification will start at the periphery of the mass and progress centrifugally. Okay? Yeah, meaning towards the center. So for this reason, you need a biopsy towards the center. When it's centripetally, when it's out, you take the biopsy out, so as to see or get tumors. This is in contrast to malignant conditions with calcification, which will often show more haphazard and non-zonal pattern of calcification. And when MRI is contraindicated, then a CT scan with contrast can allow for an assessment of the nature of the mass and its relation to the surrounding structure. A CT scan will often not give as much detail, such as subtle fat planes between the tumor and a nerve or vessel, but still can be very useful when MRI is not an option. Magnetic resonance imaging with and without gadolinium contrast is the benchmark test for assessing soft tissue mass. It allows for clear distinction of fat versus dense fibrous tissue and allows for determination of the water content of a mass. If done well, their anatomic borders to a tumor can be determined, including assessing for the presence of peritumoral reactive edema. The addition of contrast allows for the detection of cystic versus solid masses and to determine the degree of vascularity of a mass. All of this can result with the diagnostic process. Unfortunately, even with a very well-performed MRI, many masses will be considered indeterminate in nature and therefore will require a biopsy for final diagnosis. Some masses can be definitively diagnosed by MRI. Lipoma is one such example. A lipoma will have the same fat signal on all signal sequences and particularly will fully suppress on the fat suppression sequences. Cystic lesions such as Baker's cyst, synovial cyst, ganglion cyst can almost always be determined with a contrast MRI, as they will only exhibit contrast uptake at the very periphery of the lesion. Unfortunately, in many other instances, it may be difficult to distinguish benign versus malignant based on MRI alone. There are some features on MRI that may lead to concern for a more serious or malignant process. Invasion into surrounding structures such as bone, tendon, vessel, or nerve is often a worrisome sign. Similarly, heterogeneous enhancement with gadolinium is concerning for sarcoma. Peritumoral edema or less well-defined borders to the tumor on MRI are both concerning findings. If you have a poorly defined border, you should think more or less towards a malignant lesion. A large size greater than 5 centimeters and deep to the superficial fascia are also features that should raise suspicion for a sarcoma. I'm repeating this so much so that you will never forget it. The size of the lesion is important. It's more than 5 centimeters. The depth of the lesion, it's deep. If you find it intramuscular or in between the muscles, makes a difference. So you have to keep this in mind. These features taken together can indicate a very ominous process, but ultimately do not clinch the diagnosis. For any indeterminate mass, a biopsy will be required. No attempt should be made to resect an indeterminate mass without a biopsy first. An unplanned resection of a sarcoma will frequently increase the morbidity of the patient, of the treatment required, and increase the need for plastic surgery reconstruction following resection and the risk of amputation. I've seen many of the cases. If you recall in my first lecture, I spoke about the importance of a longitudinal incision. I've received a few cases where the general orthopedic surgeon took a biopsy with the incision transfer. I had to do a wider resection, a wider elliptical incision and excision of the previous incision for the biopsy. And at times I had to rotate the flap. At times I had to rotate apply skin split thickness grafts, all depending on the mistake of the surgeon on taking the biopsy. Biopsy, grading, molecular diagnostic, and staging of tumors. As mentioned previously, once a thorough investigation through history, physical examination, and imaging has been completed and the diagnosis is still unclear, biopsy is usually necessary. The technique of biopsy for the musculoskeletal system is extremely important. Wrongly placed or performed biopsies can result in catastrophic outcomes for patients, including the need for amputation. Therefore, it is generally recommended that whenever possible, the biopsy be performed at a tertiary care center with a skilled musculoskeletal oncologist and interventional radiologist. However, it is not uncommon for insurance companies to not cover the cost of a patient being seen at the tertiary care center without a specific diagnosis, or a patient may have to travel a very long distance to obtain access to such centers, which may be infeasible for them. Okay? For this reason, every orthopedic surgeon should have a basic understanding of biopsy technique. There are several general principles of musculoskeletal biopsy. All I want to tell you, I am boring you by repetition, but I'm repeating for the benefit of all. First of all, you should avoid nerves and vessels. Don't want them to be contaminated. Second, take the most direct route, as I mentioned repeatedly. Go through muscle to the lesion. Don't go in between muscle. Thirdly, not go between the two muscles, as I mentioned. Fourthly, do not undermine the skin or do extensive dissection outside of one's direct path to the tumor. This will only further contaminate the surrounding tissues. Remember, anything that is touched by the surgeon or the surgeon's instruments during the biopsy has to be resected at the time of final resection. Fifthly, keep the biopsy tract and skin incision as small as possible to achieve acquisition of adequate tissue. Again, the biopsy tract must be resected with a 2 centimeter margin of normal tissue at the time of final resection. If a drain must be used, it should never tunnel through the skin. Instead, it should be directly next to and in line with one's incision. All skin incisions should follow the same incision one would use for final resection. Many surgeons advocate drawing out your planned resection on the limb and then drawing out your biopsy along the resection incision if possible. Avoid horizontal incisions except on the axial skeleton, as these generally do not follow an extensile approach in most cases. Finally, meticulous hemostasis, as I mentioned. If you have bleeding from bone and you want to control it, you put bone wax, bone cement, or gel foam. Any hematoma that is present following biopsy is considered a site of contamination. Tumor grading. The grading of tumors is histologic diagnosis. Benign tumors are not graded, but a pathologist may report his histologic features such as increased vascularity or increased mitotic activity to indicate a more aggressive tumor. These more aggressive features may be associated with higher local recurrence rate or likelihood for benign hematogenous spread to the lungs. There are a few benign tumors that actually have a reported incidence of benign metastasis. This means the tumor can spread to the lungs, usually via the hematogenous route, but once in the lung, the tumor nodules generally do not continue to grow or take over the lung parenchyma. This metastatic event is not thought to be a fatal event. يعني مش كل metastasis لللung is a fatal metastasis. You can have lesions that settle down in the lung and they don't grow further. And for this reason, in cases of osteosarcoma with metastasis, following giving chemotherapy, and you look at the lungs, you see that there are certain nodules, you can do wedge resections. And there has been long-term survivors. So you have to keep this in mind. The two most common tumors in orthopedics that will exhibit these pulmonary metastases are chondroblastoma and giant cell tumor of bone. All malignant tumors have a grade assigned to them, which is based on histologic features that have been shown to be associated with increased likelihood of metastatic disease or decreased disease specificity survival. The grading system for mesenchymal tumors of the musculoskeletal system is normally grade 1. You look at the cell structure. Is there, are they hyperchromatic? Is there mitosis? How much mitosis is present? Then you judge whether it's a grade 1, grade 2, if it's intermediate, and grade 3, a high grade. Grade 3 is high grade with metastasis. The higher the grade, the greater likelihood for metastatic disease. And the lower the overall 5-year survival. يا جماعة كيف الوضع؟ زهقانين؟ Are you bored? يا جماعة are you bored؟
دكتور جون
ماشي الحال؟
الجماعة مرتاحين وماشي الحال. أيوه تمام.
أنا حاضر بعدني قوي بقدر كمل.
وإحنا تسلم الله يعطيك العافية. يلا
ليك هاللكشر صدقوني it's very important. هلا جايكم بعد شوي lecture on benign bone tumors and malignant bone tumors and what are the soft tissue tumors. But I'm telling you, I'm giving these in this form so that you won't forget them. The reason why we are asking tumors in the examinations, maybe you get 2 out of 10 cases of tumors, and maybe you will not get the tumor. But if you fall on a tumor and you don't know how to deal with it, it is bad. You might not pass the exam. For this reason, please pay attention. It's a very simple topic if you try to look and analyze it. يا جماعة إذا بتاخدوا اللكشة تبعي اليوم وبتراجعوها صدقوني ما بتعودوا بتنسوها بحياتكم. Okay. Features that are generally associated with the higher grade are higher يلي كنت عم بقول لكم اياها high mitotic activity, increased cellularity, nuclear atypia, greater cellular pleomorphism, multiple sizes, and heterogeneity, increased vascularity. When you have increased vascularity, this is a sign that the tumor is more or less aggressive. Look for vascular invasion. You can tell the tumor, new vascular vessels. You have to look at these. And decreased cellular features, matching the original tumor tissue. Dedifferentiation. خليني أقول لكم هيدي للدكتور خالد. نحن we ask our residents to rotate 2 months on the pathology department. عندنا slides موجودين على كل شيء pathology بالorthopedics. مفروض the resident to review them and know how to read a tumor, how to read a slide, how to go through it and put himself in a differential diagnosis. This is during the rotation of the resident in the pathology department. And believe me, our residents learn a lot about orthopedics once they pass. This does not include only tumors. It includes inflammatory bone disease, inflammatory joint diseases. It includes all these diseases. And that's the only way you can learn. Okay?
Okay.
Molecular diagnostics. Molecular diagnostics has changed the way we diagnose, in many cases, even treat tumors. The genetic information often gleaned from molecular testing has allowed for much more precise diagnosis. The type of testing done can vary from immunohistochemistry, one of the more common and least costly forms of molecular testing, to more advanced chromosomal testing, such as fluorescent in situ hybridization, which we call FISH. Immunohistochemistry can be used to detect a molecule produced by the tumor in its pathologic state. An antibody that is conjugated to a signaling substance, such as an enzyme like horseradish peroxidase or a beacon molecule like fluorescein, is used to identify the presence of a specific antigen. An example of such a test would be S100 staining in nerve tumors. We now use a plethora of different molecular diagnostic tools to assist in the diagnosis of musculoskeletal tumors. The table next slide provides examples of some of the more common examples, but is by no means an exhaustive list. So if you look over here, I've shown this before, but you should identify each. Baslan Ewing sarcoma, you have a translocation, 11 to 22 and 21 to 22 in 10% of the cases. And the testing is the FISH, RT-PCR, and you do other common tests, CD99 and IHC. I diagnosed a young girl with Ewing sarcoma by just doing a CD99 on her. Synovial cell sarcoma, don't forget this question. I usually put the question. It's a translocation of X18, SSX, SYT, and FISH, IHC for epithelial membrane antigen cytokeratin. Then you have the extraskeletal myxoid chondrosarcoma, translocation 9 and 22, and the fish RT-PCR. And you have a whole list. You have to go through them. You have to memorize them. You have to know what they are. Believe me, you have to know, because these come in multiple choice questions. The technique of fish utilizes specific DNA probes that bind to regions of the cellular DNA. These probes can be used to detect chromosomal rearrangements seen in translocations. If two probes are normally on separate chromosomes, if the fish detects their presence side by side, then there has been a chromosomal rearrangement that has brought these two areas of the DNA together. This is an extremely sensitive test for looking for specific chromosomal translocations. Ya Jama'a, we identify Ewing sarcoma by chromosomal translocations. We identify osteochondromas by chromosome translocations. You have to pay attention to this. Reverse transcriptase polymerase chain reaction is another useful diagnostic tool. This method allows for detection of specific fusion proteins that are often formed as a result of a translocation. The RNA is reverse transcribed into cDNA, which is then amplified to allow for visualization of this particular gene, which would normally not be detected in non-neoplastic tissue. Finally, one can do direct DNA sequencing or quantitative PCR to look for the presence of specific abnormal genes with a known mutation. Staging of tumors, we spoke about this. I'm not going to go. I follow the Enikin classification. There are other classifications, and we don't need to repeat this. Okay? So this is it. These are the AJC, staging bone sarcomas. You have to know them. You have to know what a class 1 is, whether it's intracompartmental, what totally, and then you say what is the grade, is it benign or malignant? It can be extracompartmental and yet have a low grade. You have to know how to classify the Enikin, and the type 3 is one with metastasis. You have to know these, okay? So don't forget this. Now coming about adjuvant treatments. Adjuvant therapies often play a critical role in the management of patients with bone and soft tissue sarcomas. They can dramatically affect local recurrences, rates, and overall survival for certain sarcomas. This means that the care of these patients must be closely coordinated with our radiation and medical oncology colleagues. These treatments are not without side effects, and as surgeons, we need to be mindful of this relation to our own treatments and counseling of patients. Unfortunately, not all sarcomas respond to adjuvant therapy, in which case surgery becomes the only curative option. An example of this is chondrosarcoma. Radiation and chemotherapy don't affect it. So we have to depend on surgery and try to do our best resection with a margin. Now, Adjuvant therapies in the treatment of sarcomas, osteosarcoma, it's excellent. Yes, it has improved with treatment. Ewing sarcoma, yes, yes. Synovial sarcomas, yes. And radiation therapy, yes. But إجمالا bone sarcomas, whether osteosarcoma, whether Ewing sarcoma, whether chondrosarcomas, these don't respond well to radiation therapy, and especially in children with a Ewing sarcoma, we don't like to give radiation therapy in spite of it being sensitive. Why? Because it affects the growth centers and they end up having deformities. Osteosarcoma does not respond to radiation therapy. In the past, we used to give it. Now, finish. Now, chondrosarcoma doesn't respond to anything. Okay? High-grade soft tissue sarcomas, chemotherapy is controversial, but they respond to radiation. إجمالا, the soft tissue tumors respond to radiation. Chemotherapy. The story of chemotherapy is best told by looking at osteosarcoma. In the 1960s, the vast majority of patients received amputations for osteosarcoma. And those patients went on to succumb to their disease in about 80% of the cases. يعني 80% كانوا يموتوا. In the early 1970s, physicians started exploring chemotherapeutic options after seeing good results in leukemia and lymphoma patients. High-dose methotrexate was one of the first agents used for this purpose. It then became evident that the use of multi-agent therapy resulted in even better results. The three agents that stood out were methotrexate, doxorubicin, and cisplatin. With this three-drug combination, the 5-year survival rates jumped from a dismal of 18% to around 65%. By the mid-1980s, this drug regimen had been established as the standard of care for high-grade osteosarcoma. This drug combination is still the backbone of all therapies for osteosarcoma today. And unfortunately, we have not been able to move the survival rates further along with the addition of other agents or treatments thus far. So this combination of the three drugs has proven to be effective, and other drugs have not added to the survival rate. Some institutions also add ifosfamide for high risk or metastatic patients, but its benefit is controversial. Most patients receive neoadjuvant chemotherapy, which means 2 rounds or 2 sittings of chemotherapy before the surgery, followed by standard adjuvant chemotherapy of 4 rounds after the surgery, 2 before and 4 after. This usually totals around 9 months of chemotherapy. The main purpose of the neoadjuvant chemotherapy is to allow for pathologists to provide an assessment of initial response to chemotherapy. Good responders, greater than 90% necrosis, have a better prognosis than poor responders. Yani, this is known as the Heuvis. Heuvis was a pathologist, and he found that following the neoadjuvant treatment, which is 2 rounds, you do the surgery, then you take a specimen at the same time, and you analyze it. If there is necrosis, more than 90% of the tumor, then you say that this patient has good prognosis. If it's less than 90%, then we say they have a bad prognosis. Jehovah's classify them into 4 types, but the one who has more than 90% is the best result. The same story can also be told for another bone sarcoma, Ewing sarcoma, osteosarcoma, and Ewing sarcoma make up the vast majority of chemotherapy-sensitive cancers that we, as orthopedic surgeons, primarily treat. It should be noted that all of these cytotoxic agents result in dysfunction of the immune system and therefore increase the risk of wound complications and infections. Other side effects that are important to note are doxorubicin, which increases the risk of cardiomyopathy throughout the life of the patient. I'll tell you this. This is a question we love to ask, which is, which of the following drugs has the effect of producing a cardiomyopathy? And you should answer doxorubicin. The next major advancement that will happen in the treatment of these other bone sarcomas will be moving away from these cytotoxic agents that simply blast the rapidly producing cells with poisons and toward more targeted therapies with hopefully adverse effect profiles that can be tolerated. One thing from a surgical standpoint that became evident in the era of chemotherapy discovery for osteosarcoma was that it was not the local disease that was resulting in the death of these often young children, but the microscopic systemic disease that was present at the time of initial evaluation. As a result, surgeons began using more limb-sparing techniques, moving away from amputations as the surgical option. Today, less than 10% of patients receive an amputation for osteosarcoma. The rate was above 80% 40 years ago. Now it's only 10% that we have to do in amputation for osteosarcoma. Radiation therapy, like chemotherapy, the use of radiation therapy has greatly improved patient outcomes in certain sarcomas, primarily in the form of local control. There are now different forms of radiation therapy, but the general concept is that tumor cells are exposed to particles or waves that lead to DNA damage and resultant cellular apoptosis. In an ideal world, those waves and particles would only be targeted to the cancer cells themselves and avoid normal tissues. But unfortunately, in most cases, the surrounding tissues are also exposed to the radiation. The smaller the field of radiation, the less exposure there is to the surrounding normal tissue. The standard dose of radiation for soft tissue sarcomas is 50 to 66 gray, which is double the dose given for most metastatic disease. The effects on the tissue are exponential and not linear. However, so the tissue damage as a result of this dose is significant. In orthopedic surgery, soft tissue sarcomas are the most common cancer for which radiation is used. It was discovered through a series of trials that radiation therapy greatly reduced the risk of local recurrence in surgically resected soft tissue sarcomas. This was especially true for large and high-grade sarcomas and for sarcomas where surgical margins were negative. This latter finding points to the fact that even though surgeons felt they were doing an adequate job at resecting the soft tissue sarcoma, in many instances, there were cells already outside of the surgical field. Radiation allows for the killing of those cells outside the surgical field. It should be noted that although there is a reduction in local recurrence rate with the use of radiation therapy in soft tissue sarcomas, there is not a direct association with overall survival. However, local recurrence is associated with a poorer overall survival. There is no difference in local recurrence rate with preoperative versus postoperative radiation. The use of preoperative versus postoperative radiation tends to be institution-specific. Preoperative radiation therapy carries a significantly higher wound complication rate, so some surgeons prefer to give postoperative radiation. However, with postoperative radiation, the dose of radiation and field must be higher and bigger, respectively, to address the surgical edema. For this reason, many radiation oncologists advocate preoperative radiation, especially with vital structures, bone, nerve, and skin. As noted, radiation kills the cancer cells within the field of exposure. It also, unfortunately, has deleterious effects on other tissues near or in the field of exposure. We have already mentioned wound complications due to skin and subcutaneous tissue damage. It is also not infrequent to see nerve damage, permanent lymphedema, lymphatic damage, and osteonecrosis and bone fragility. The nerve and bone damage can be very late complications, happening years later. Many surgeons will prophylactically stabilize a long bone that has been in the direct effect of radiation for a soft tissue sarcoma for this reason. There is also a very low but real rate of post-radiation sarcoma in areas that have received radiation. The incidence is thought to be less than 1% of patients who receive radiation for various reasons. The functional outcome measures, the Musculoskeletal Tumor Society score, is a scoring system that was created by members of the Musculoskeletal Tumor Society in 1985 and modified in 1993. It takes the sum total of 6 measures: pain, function, emotional, support, walking, and gait, in which patients are given a score from 0 to 5, with 0 representing the worst possible outcome and 5 presenting normal and societal baseline. A maximum score of 30 is possible. The major critic of Musculoskeletal Tumor Society score is that its original design, it was meant to be filled out by the surgeon, so it is not really a patient-reported outcome measure. It also has a ceiling effect for looking at true outcome, and some argue it is just not comprehensive enough to pick up subtle differences in function. So this is what there is the SF36. I will not go through these because these are for you to memorize. So, in summary, when clinical presentation and imaging fail to provide an answer, biopsy, often with molecular testing, is an extremely useful tool. The biopsy of tumors must be taken quite seriously, as performing a poor biopsy can lead to devastating consequences for patients. Once a diagnosis is determined, an understanding of treatment is significant. Various treatments for malignant cancers, including chemotherapy and radiation therapy, are presented. Knowing when to use such approaches is necessary for good patient care. We have also discussed the future role of functional testing in orthopedic oncology. In our current era, focused on evidence-based medicine, quality measures, and functional outcomes, these outcome measures will become increasingly more important in daily practice of orthopedic oncology. The key study points, you have to know these. Distinguishing soft tissue and bone tumors is a key starting point to the treatment of a patient with musculoskeletal tumor. Pain or lack thereof is not indicative of malignancy in soft tissue tumors. It is important to understand when various imaging techniques would be most helpful. Plain radiographs are an excellent starting point for most bone tumors. MRI is helpful for soft tissue tumors, bone masses with a soft tissue component, and any malalignment tumor. Understanding the key principles for performing a safe and effective musculoskeletal biopsy is paramount to care of patients with musculoskeletal tumors. Since contaminated margins increase the risk of local recurrence, careful preoperative planning is essential. The biopsy site must be excised en bloc with the tumor. Close margins are acceptable in an effort to preserve major neurovascular structures when they are not invaded by the tumor, and drains must exit close to the surgical wound. Several studies have described an appropriate margin as greater than 1 millimeter, including an anatomical barrier, capsule, tendon, fascia, cartilage, periosteum. A study showed that 5 millimeter margins without use of adjuvant radiotherapy or 1 millimeter margins with adjuvant radiotherapy were adequate. Another study corroborated the view that limited resection achieved a negative margin, but less than 1 millimeter may be adequate in the setting of modern multidisciplinary treatment. Thus, radical resection of the whole compartment is currently considered not necessary, and amputation is generally reserved for cases when free margins cannot be achieved without loss of limb function. Now, we spoke about chemotherapy. Let me see. And thank you. Thank you very much. Any questions? يا جماعة, any questions?
صراحة لا دكتور جون.
Any questions يا جماعة؟
دكتور جون شكرا لك كثير جدا، والجماعة بيشكروا كلهم واستمتعوا بمحاضرة اليوم، رائعة جدا ومفيدة للشباب
بس بعرف انه
يعني شملت كل حاجة.
ليك خالد هالمحاضرة اليوم زهق لإلنا ولإلهم، لأن
طبعا
هيدي it's a pure memorizing conference. You have to know the memory. هلا جمعتي الجاية رح بيكون عنده لكشة على الميتابوليك بون ديزيز. And believe me, I know a lot about it. جمعتي الجاية يعني
ايوه
لحتى ما نروح الجمعة نرجع للأوردرلي فاشن. اوكي دكتور خالد حكيك حدا حكى
هلا انا اتفقت مع ميساء، هلا بكلمها بتصل لها اتصال عندها طيب. واشوف وارجع لك خبر.
رجع لي خبر، لان انا حابب انه واحد منكم يكون موجود.
انا بكلمها
لان على الزوم انا بنظري هيدا تضييع وقت،
يعني ما
تضييع وقت. ايه
ما بيفيد يعني.
ما بتوافق؟
لا ما بيفيد يعني
بالساعة شو بدنا نعمل؟
ايوه كلامك صح، يعني ما بكفي الوقت يعني.
ايه لان ليك بدنا نمشيهم كلهم. انا قايمه قيمتي انه هالسنه لازم نمشي الكل. السنه الجايه
ايوه
بدكم تتعودوا على الاجريمنت، على القانون وتمشوا فيها. بس هالسنه لازم يمشوا الكل. وهيدا حكيت انا وجواد تبع عراق، حكيت انا وياه وهو بيوافق معي. هلا المهم دكتور عادل يقدر يقتنع لحتى بهالخصوص. هلا خلينا انا بعتقد تيجي ب 21 شهر تقعد تجتمع معنا، تسمعنا نحن وعم نعمل الميتينج، وساعتها بنحل كل شيء. اوكي سير.
انا بكلم ميساء. شكرا سير، الف شكر. بكلم ميساء وارجع اكلمك.
اللي شو قررتوا.
هلا اوكي.